Good afternoon. I'm Dr. Ankur. I'm a medical director of pain management over at AMITA at the Neurosciences Institute. So we're at Alexian Brothers, St. Alexis, Glen Oaks, and also down south, and now off into the President's Hospital world. And today I'll be talking about chronic pain, something that I think a lot of the stands here are in reference to. So let's start out by defining what chronic pain is. Chronic pain is pain that's been going on for more than 3, sometimes 6 months, but more importantly, it's beyond the time of normal tissue healing. So we separate that from acute pain. Acute pain is pain that has a known cause that's been going on for less than 3 months. So if you break a bone, if you have surgery immediately afterwards, you have acute pain. Chronic pain is pain that just persists after that, but not necessarily has a known cause. So you had a surgery, but the pain has been going on for 6 months after that. So everything's healed up. The surgeon has said, hey, I don't see anything really wrong, but you're still having pain outside of that. And that's a very important differentiating factor because it really guides our treatment plan, which we'll touch on later on. So it's important to know, as most of us here do, that chronic pain is in fact very common. In fact, pain in America is the #1 reason that people go to see the doctor to begin with. It is now, more people have chronic pain than cancer, heart disease, and diabetes combined. So this is something that we all have to get comfortable talking to each other about, whether you're on the provider side, if you're on the patient side, knowing that you're not alone in all of this. On top of this, so this is the sheer number. We say, well, more than 30% of Americans are living with some form of chronic or severe pain. A different perspective is the cost that this puts on the healthcare system. So more than $300 billion a year is dedicated to managing chronic pain. So not only are patients paying for this with their day-to-day life, also tax dollars are going to this and healthcare costs are going to this. And this is ever rising. So that number was back from 2012. And it's been on the upswing since then. So this is truly something that is an epidemic in itself, and it has led to another epidemic, which we'll talk about in a little bit. So how was chronic pain managed in the past? This is not something that over the past 5 years or 10 years we've been dealing with. Americans and mankind has been dealing with chronic pain since 1600. 1,000, 2,000, 10 million years ago. But really a lot of attention has started going into it in the 70s and 80s. Before then, you were more or less resigned to, well, this is my lot in life. I have chronic pain, this stinks, woe is me. And there were some over-the-counters, there were some snake oils and stuff like that really dedicated to trying to help, but we really have no science behind that. Now, on the patient side, that's very frustrating, but also on your family medicine doctor or your primary care doctor, that's very, very burdensome too. You have no options. So doctors were getting quite desperate. So around that time, around the 70s and 80s, there, for various multitude of reasons, we're not going to get into all of them, but pressures from pharmaceutical companies, from healthcare providers, as I mentioned, government agencies, as well as patient campaigns, resulted in opioids being prescribed for chronic pain. And what we found is that, hey, we can keep on giving opioids and kind of dose it to effect until patients come back to the appointments, they say, hey, I'm getting some relief. And that really kind of opened the floodgates to chronic opioids being prescribed for non-cancer chronic pain. And so since then, since the 1980s, let's see if you can look at this. This goes from 1980 to 2000. You can see that it's been an exponential rise in the total opioid consumption, as to where we are now, America is the #1 user of prescription opioids in the world. We are not a blue-collar country anymore. We're not a third world country where a lot of people are just manual labor. We are a first world country, yet we consume the most amount of opioids. We consume 99% of the world's hydrocodone, which is Norco, 80% of the world's oxycodone, which is Percocet, and 60% of the world's hydromorphone, which is Dilaudid. So we did it. So what's interesting with all that, we see, well, we're prescribing more and more medications based off of what we knew in the 1980s, we should have no pain at all. Well, the amount of pain has not changed from 1980 up until today. So patients are reporting the same amount of pain despite getting more and more opioid medications. So what's happening? Because these aren't candy pills, right? These aren't Skittles. Well, we've seen an increase in the rise of opioid overdose deaths. This has gotten to the point where more people are dying from opioids than motor vehicle accidents. In Illinois, everyone likes to point to, well, gun crime, gun violence in Illinois. More people die from opioids than gun violence in Illinois. More opioid overdose deaths than homicides in general. So, that really happened in 3 waves. So you see wave 1 was 2000 to 2004, and that's prescription opioids. That's the Norcos, the Percocets, the pills coming from the doctors to the patients. And that spearheaded a second wave, which is a rise in heroin overdose deaths. Now, a lot of people look at that word of heroin and they're like, whoa, that's some real stuff. But why does that go hand in hand? Well, opioids are heroin are opioids. They come from the same place. So what happened is that patients are getting more and more opioids, and one of the worst side effects of opioids is that they're addictive. And now their body is craving more and more than what the physician is prescribing, so they're running out of their medication early. And they start saying, well, what's a cheaper option, or what else is available? First step, they start misusing their friends' opioids. So 40% of prescription opioids are misused. So that eventually runs out because that friend needs the opioids too. So then they say, well, what's cheaper? That's where heroin comes in. And interestingly enough, there's a book called Dreamland that really highlighted this. And this was kind of what really made it up to Barack Obama, actually. This is the book that he read that really pushed the start of this opioid campaign, or this opioid epidemic campaign. But this correlated with the rise of black tar heroin coming from Mexico. So that started creeping up in the 80s and 90s, and that kind of leads us into wave 2, where prescription opioids are now resulting in the rise of heroin overdose deaths. Another statistic to bring out is that 80% of patients who use heroin recreationally or due to addiction started with prescription opioids. So that's a straight transition right there. And that wave got us to 2011, and now we're in the midst of wave 3, which is the rise of synthetic opioid overdose deaths. So that's where you read the news, or you go online and you hear about fentanyl-related deaths. And other opioid products coming from China, which are laced in the heroin that patients are overdosing on, or even marijuana that patients are using illicitly can be laced with fentanyl or some of these other synthetic opioids. So that's kind of where we are. And so when we look at the numbers, we say 115 people die every day in the United States from opioids in general. 40% of that is from prescription opioids. So that's about 40 to 60 people a day dying from prescription opioid overdose. And that's 4 times as many as 2000 or 1999, and it's still rising. In Illinois, we are kind of moderate there. So we average about 1,800, 1,900 people dying every day from opioid-related death. And like I said, that's more than homicides, more than gun violence, more than motor vehicle accidents. So all of us have heard about the opioid epidemic. Well, it really got its start from the chronic pain epidemic. So we call these twin epidemics. So what are we doing? Well, locally, this is from the State of Illinois Opioid Action Plan signed by Governor Rauner. Our goal is to reduce opioid-related deaths by 33% against estimated deaths in 3 years. So what does that mean? Like I said, around 1,800, the exact number is 1,889 deaths a year has been going on, but that's a linear progression. They just want to cap that. They want to say, hey, we'll take 1,889 deaths a year for the next 3 years. We just can't have that go up. So that's really what that number means. And that comes down to 3 parts. It comes down to prevention, treatment and recovery, and response. So at this point, it's important to separate what kind of opioid type of patients we're dealing with. Now you have the heroin patient, the one who's really gone far, and that response is addiction and getting them to the right resources. We're gonna, as important as that patient population is, we're gonna not focus there. We're gonna focus on the chronic pain patient. Now the chronic pain patient, when it comes to opioid prescribing, is in two categories. You have one category, patients that have chronic pain that are not on opioids, and they're going through the treatment algorithm with their physician or with their therapist to manage their chronic pain. And then you have that second group, which is the patients that are on prescription opioids. And the question really is, what do we do for those patients? Do we keep them on the same dose? Do we reduce their dose? Do we stop prescribing? And that's really been the dilemma in healthcare when we talk about kind of public health there, is that's a very big patient population. So when we talk about prevention, some of this goes on the doctor-patient relationship. So safer prescribing and dispensing. So the state of Illinois, as well as 48 other states, have a prescription monitoring program. So this is a program where doctors can go online and check to see when and where the patient filled their last opioid or controlled substance. So this can help with overprescribing or patients going from physician to physician getting multiple prescriptions. Excuse me. Education and stigma reduction. So that's getting out into the community, like we're doing today, so I get to check this box, and saying that we're educating about opioid prescribing and what the risks are there. Monitoring and communication, that's when we talk about, well, in the electronic medical records, what can we do? How can we collaborate with other physicians, with therapists, counselors over there? How do we coordinate to make sure patients are really getting that multidisciplinary care? When we talk about treatment and recovery, for patients that have opioid use disorder or opioid addiction, whether it be from illicit drugs or noticing that, hey, they're using their prescription pills too much, or they're kind of making that transition over to that addiction side. How do we improve their access, have that conversation with the patient, and get them where they have to go, whether that's on the pain management front or the substance use front. The response is the stuff you read on the news about first responders, naloxone, Narcan, giving medications to patients that are who have already overdosed, and as well as medications like methadone, buprenorphine, also called Suboxone, which are life-changing or life-saving interventions, and getting that access throughout the community. So this is the point when I give a lot of talks where I say, hey, we've done a lot about awareness, and all of us know about the opioid epidemic. I'm assuming everyone here has, and I've given a lot of talks about it. So what do we do now? This is kind of that push. We really need to focus on making a difference now. Enough people know about it. Now let's go and make some changes. So when it comes to pain management, which is what I do, our focus has really been, we need to redefine what chronic pain management is. Most patients, when they come to see me, their goal is, I want to get rid of this pain forever, which is noble, it's great, probably not realistic though, because this is chronic pain. This is something that the patient may have been living with for 10, 15 years, and with the snap of a finger or a use of a needle, that pain is not going to go away completely. I would love for it to. I'd probably already be retired if I could do that, but we can't. So a lot of it is shifting that focus. And that first slide when we talked about comparing chronic pain to diabetes, high blood pressure, and cancer. Well, let's look at diabetes and high blood pressure. A patient can get their diabetes under control. They can have their blood pressure under control. That does not mean they're cured of diabetes. That doesn't mean that they no longer have hypertension. That means that they're in control of it. And that's the goal with chronic pain. We have to look at this as a chronic condition where you can control it as opposed to it controlling you. And that's really been what our focus has been, and a lot of other pain management doctors. So to do that, there isn't one silver bullet. And that's another brutally honest conversation to have with the patient. The patient comes in and sees me, they say, my doctor said that there's an injection that you can do that can make my pain go away. Incorrect. There's an injection that may help your pain, but it has a shelf life, right? So during that time that patients are feeling better, they need to be doing something else to improve their pain management so that when the injection wears off, their body has had that time to recover and strengthen up, that it's able to be more in control. So how do we divide that? Well, practically speaking, I think a lot of our presentations have had circles, so this fits the bill. We talk about multidisciplinary care, so a multiple pronged approach. And this is commonplace, it's available everywhere, but we divide it into movement-based therapies, integrative therapies, behavioral therapies, medical procedures, and medications. I further differentiate this into active versus passive therapies. So active therapies are what can you do for you. Passive therapies are what can I do for you? What can a therapist do for you? Or what can a healthcare provider do for you? And both of these are equally important, but they have to kind of play with each other. Because just doing a passive therapy does not get you long-term success, and that's just kind of the reality. So when we look at procedures, that's where injection-based procedures, so we talk about trigger point injections, epidural steroid injections, spinal cord stimulation. These are things that can really help a lot of people, but they don't go after muscle strengthening. They don't go after anything like that. Medications. I always tell patients, medications are not a long-term goal. Even though it's relatively easy to get a prescription for even just an anti-inflammatory or a muscle relaxant, it's easy to get that. But instead of looking at it as pill bottle at a time, so 1 or 3 or 6 months at a time whenever you go to your doctor to get that new prescription, look at it at the shelf life of that pill. So if that pill lasts for 6 hours, that means that medications are giving you 6 hours of relief at a time. And that's how the mind starts training the body to expect that, okay, well, this is only going to work for 6 hours. And then at the end of the 6 hours, you're starting a treatment up again, which is the new pill. So when we talk about active-based therapies and movement-based therapies, that's exercise therapy, physical therapy, and as I mentioned, that's strengthening the muscles. That can actually reverse some of these chronic changes from arthritis, from a degenerated disc. These things are actually reversible to some extent, but that only happens if you're strengthening the body. Integrative therapies, that's where we talk about massage, counter strain, acupuncture, chiropractor, yoga, tai chi, mindfulness. So our goal here is that mind-body connection, and that's why it's integrative. And we've learned that this actually has a lot of first-line data behind it. And it seems like a lot of other specialties in pain management, so I can't speak for an aesthetician, but there's a lot of overlap there, right? So that mind-body connection really goes far for chronic pain because close to 80% of patients with chronic pain have underlying depression and anxiety, which leads us to behavioral therapy. So cognitive behavioral therapy, depression, anxiety groups, individual therapy, those kind of link into really getting the patients to focus on the other causes of chronic pain. So what we know in the chronic pain brain is that it acts differently than the acute pain brain. What I mean by that is when you have a surgery, let's say you had surgery on your foot, there's signals that go from your foot to your brain saying, hey, this hurts. And the part of your brain that deals with pain management says it lights up, it sends you signals, and it relies on your body as well as maybe some medication or whatever to bring that signal down. In chronic pain, we see that same signal, but we also see a flood of signaling going not just to the pain part, but also to the part that deals with anxiety, depression, function, mood, and behavior. And so that's that chronic pain cycle where patients say, when I'm in pain, my mood's worse, I treat my loved ones worse, I move around less, and then that makes my pain worse. So that's part of that behavioral, integrative, movement-based therapies, aka active therapies. So we're headed in the right direction. I think a lot of providers are working with therapists now. I think it should get better with time, as well as improvements in technology. But I think on where we are in terms of the chronic pain epidemic and the opioid epidemic, we definitely need to be working on more than just awareness. So in conclusion, chronic pain and opioid misuse are twin epidemics. Resolving one involves resolving the other, right? And solving the chronic pain crisis involves changing to a multidisciplinary treatment plan focus on changing the conversation from eliminating pain to being in control of pain. So I think I have a couple minutes, I'll take any questions. Or we're not doing it, we're just going around, so. I'm fine with it.